Welcome, everyone. My name is Sylvia Romer, and I'll be your moderator for today. We are very pleased that you have joined us for an interesting and educational webinar presented by CaravanHealth ACO. The presentation will be followed by a Q&A session. We're very fortunate to have several presenters today. From CaravanHealth, we have Taylor Campbell, Manager of Business Development, and David Latzer, Regional Vice President. From Alcona Health, who is a client of CaravanHealth, we also have Nancy Spencer, CEO, and Susan Hose, CFO, COO. Before we get started, there is some housekeeping to take care of. I need to read a legal statement, so please bear with me for just a moment and then we'll get started. By participating in this Alterum Institute webinar, you automatically agree to authorize recording of audio and visual content presented during this event and consent to subsequent use of the recording in the public domain by Alterum Institute. This recording may include questions and responses provided by you during the live event. The recording will be made available after the conclusion of this event and part of the Alterum Institute webinar archives and will remain available indefinitely. If you do not wish to consent to the recording, please do not join this event. If there are any questions, please contact me at sylvia.romer@alterum.org. Alterum Institute webinar is intended solely to provide information to the public. The views and opinions expressed as part of these webinars do not necessarily state or reflect those of Alterum Institute. It is not intended, nor can it be relied upon, to create any rights enforceable by any party in litigation or to endorse any other organization or service. With respect to these webinars, neither Alterum Institute nor any other employees makes any warranty, express or implied, including warranties of marketability, fitness for a particular purpose, or assumes any legal liability or responsibility for the accuracy, completeness, or usefulness of any information, services, products, or processes disclosed, or represents that its use would not infringe on privately owned rights. So now that we have that done, we'll get down to the fun part. Thank you again, everyone, for joining us today for our webinar entitled Alternative Payment Models, CaravanHealth ACO. CaravanHealth is a mission-driven company helping providers and community health systems make the transition to value-based health care. They build and manage accountable care organizations to support physicians and community hospitals and their goals of improving patient care and clinician satisfaction and financial performance. During today's presentation, all participant lines will be muted. If you have a question, please type it into the question box in your GoToWebinar interface, and we will address the questions during the Q&A sessions. Due to the large number of attendees for today's webinar, we may not have time to answer all of the questions. If we do not address your question during today's broadcast, you will receive an email with the questions and responses. A link to the recording of this presentation, along with a slide deck and contact information for CaravanHealth, will be provided to you via email. Today, Taylor will provide an overview of their organization to include APM structure, performance record for quality and cost savings. He will also review time commitments, workload, cost support, technology commitments, and financial incentives. Information provided will help you determine if you would benefit from further discussions with CaravanHealth. Following the presentation, CaravanHealth and Alcona teams will take time to answer your questions that you may have. Please note the information that you will hear during this broadcast is current as of today. So we're going to start today's presentation with Taylor Campbell. Taylor is the Manager of Business Development for CaravanHealth. Taylor, it's all yours.
Thank you very much, Sylvia, and good afternoon, everyone, and happy Halloween. Thank you so much for joining us today. We'll go ahead and get started. For those of you who are unfamiliar with CaravanHealth, Sylvia, if you want to change the slide to the next, that would be great.
Sure.
For those of you who are unfamiliar with CaravanHealth, we were founded to support success in value-based care, help providers collaborate, help them share information, and ultimately help them succeed in ACOs. We've grown to serve over 600,000 attributed Medicare patients. That's over 26,000 clinicians and over 250 health systems nationwide. We've managed 45 ACOs across the country, ranging in size from 5,000 attributed lives to 225,000 attributed lives. And if you take a look at that map down below, you can see our nationwide footprint. Next slide, please. A bit more about our ACOs. Our largest ACO, which also happens to be the largest nationwide ACO in the country, is what we call the CaravanHealth Collaborative ACO, with 132 participants and over 230,000 attributed patients. And I'll talk a bit more about why we decided to go with such a large ACO in future slides. In addition to that, we have several statewide ACOs in partnership with the state hospital associations in Mississippi, and we are going to be launching 3 more statewide ACOs in partnership with the state hospital associations in Florida, Idaho, and Texas. Next slide, please. We've had excellent results over our experience in the Medicare Shared Savings Program, also known as the MSSP. All of our clients are performing very well in the MIPS quality scores as well as the ACO quality scores. We've generated significant savings for CMS and significant savings on a per patient level as well, as you can see on the slide. These results have translated to shared savings for our clients as well as other financial benefits that I'll cover in a few more slides. Next slide, please. Here's just a quick snapshot of several of our current partners. Some of you may recognize Avera, StrataMed, maybe even Crouse Health and Knox Community Hospital over in Ohio. Again, this is just a quick snapshot of several of our partners. Next slide, please. Now, our secret sauce, as we like to call it, is organized into these three pillars. Developing and implementing a new approach for your primary care clinics, utilizing new resources, new workflows, and actionable data, arguably the most important for your practices to use. You need a way to change how you operate, manage that change, track that change, and we need a way to hold all of our partners accountable for the programs that they have committed to be successful in the ACO. And of course, you need the backbone of data and analytics. We've built a robust platform of analytics that's based on what ACOs need and not based on the coolest looking widget or report out there. You know, the last thing medical staff want are 30 more reports to look at the end of the day to figure out how they can be successful in their ACO. Next slide, please. And these next few slides are kind of in a question and answer format. These are concerns that we've heard, or common concerns that we've heard from our clients and other prospects out there. Next slide, please. So the number one problem we see with ACOs across the country is scale. Prior to 2018, we had 23 ACOs, all under 20,000 lives, and we were seeing results that were quite literally all over the board. Some had huge swings in savings and losses rates, and we noticed just a ton of statistical noise. We had everyone working on the same initiatives, being held accountable in the same way, and we were sitting there scratching our heads every single day, kind of wondering what we were doing wrong and why this was. But all this was until our founder, Lynn Barr, sat down, and I believe she was on a plane at the time, and plotted the performance of every single ACO in the country, and not just Caravan ACOs. And you can see that chart that she plotted at the bottom left hand of your screen. And on the x-axis, you can see the size of the ACO. And so as you move farther to the right, the larger the ACO is. And then on the y-axis, you can see the savings and losses rates. So positive 10, 20, 30% and negative 10, 20, 30%. And so if you look on the left side of that chart, you can see that that is where most ACOs live, under 20,000 lives. And then if you look at the savings and losses rates, there's tons with huge 10% swings. And if you actually plot their performance year over year, you kind of get the same looking chart. And so what we kind of realized after looking at this is, well, as you move out to the right side of the chart, you can see obviously there are larger ACOs, but the performance is not just much more predictable, but the statistical noise is almost completely eliminated. And that is the approach that we decided to take with our large collaborative ACO that I mentioned earlier. I mentioned that we have over 220,000 lives in that ACO, and so if you tried to plot that dot here on this chart, it'd be way off the map. And so with that approach, we've seen tremendously successful results. We are in the money with the shared savings, and we can already notice that after Q2 of this year. Next slide, please. Another common problem that we see in communities beginning in an ACO is truly educating the entire staff about the program and what it's going to take to be successful. To kind of mitigate this, right off the bat, we work with our clients to both identify the necessary staffing requirements and train them on how to do all this work. And that's going to require high quality templates, workflows, a lot of training in person and remotely, and access to experts who can help deal with problems as they arise, because we can't exactly predict everything that you're going to encounter in your ACO experience. So it's important to have resources at your fingertips to help you guys be successful. And this all involves working with our primary care workflow experts, training your staff, and supporting analytics that your practices can actually use, like I mentioned earlier, as well as right-sizing your practice staff, meaning getting the right people doing the right work at the right time. You know, for example, having nurses lead annual wellness visits, which I'll get into later. Next slide, please. Governance and management is actually a really underappreciated problem for ACOs and health systems, you know, in these programs. Frequently, we'll see our clients working on a million different initiatives that are brought up every quarter and then forgotten about 4 quarters later. It's really hard to kind of break through all the noise and focus. Now, having a neutral third party like CaravanHealth to call all the balls and the strikes in terms of the progress of the ACO and its success is important. So we bring objective data and perspective to the management process. It's built around community level and steering committee meetings where everybody involved, every stakeholder and leader, they come together routinely to check progress using data. And we bring practice and community scorecards to those meetings as well, and to roadmap calls, which is our monthly touch points with every clinic to ensure that, you know, progress is truly being made. And if you go to the next slide, we actually have an example of one of these scorecards that we bring to these meetings to kind of track progress and help you guys understand where you're at. Now, you can see on this scorecard that we track leading indicators like, do we have the right staffing handled? What rates of annual wellness visits and chronic care management have we achieved? And what are we doing if we aren't meeting our goals? As well as tracking quality in terms of, you know, outcomes and processes to make sure that services that are being provided during an annual wellness visit, for instance, are meeting all of the patient's needs. Now, if your community shows low engagement, for example, or you simply aren't meeting AWV or CCM goals, you'll be put into a program that we call remediation. If after a certain amount of time in remediation, your community continues to show no improvement or engagement, we do reserve the right to ask you to leave the ACO. And that's how we truly hold every ACO participant accountable, is really holding the staff that have committed to this program accountable for the work that, you know, we are helping you to be successful at. Next slide, please. We also see routinely, actually, ideas on how to generate shared savings. However, no concrete strategies to truly get there. We have a primary care plan and system transformation plan to get you started on the path to shared savings. We'll focus on initiatives with the highest likelihood of success, like primary care programs, ensuring that your HCC coding is on track, and truly making sure that your patients are receiving the right care at the right time and in the right place, and all while effectively managing your total cost of care. Next slide, please. I briefly mentioned some of the technology that we bring to the table earlier. I could easily spend 2 hours discussing this, but we've done some extensive scans of the healthcare IT space, and we actually decided to build our own truly ACO-based platforms for our clients. We've built a series of specific resources for our clients doing this work to bring them the info that they need when they need it. Additionally, we call it the CaravanHealth portal, and this portal is all, you know, in a HIPAA compliant environment. you can access your Caravan Compass reports, which is our in-house analytics module that I'll get into in a moment, as well as accessing other resources, educational materials, webinars, and direct lines to your regional team, which I'll also get into in a moment. Next slide, please. Now I'll get into a bit more about our ACO methodology. Next slide, please. Now, the key to ACO success is, first of all, understanding how to win in the program, how to be successful. And from our experience, it's managing your patients better than fee-for-service. It sounds really simple, but it's difficult. We all know that, and that's focusing on wellness and prevention, chronic care management. It's also accurately coding chronic conditions, and actually, in the new rule that was released for the MSSP just under a year ago, ACO participants are eligible to receive up to $300 per patient if they show a certain percentage improvement in their HCC coding, which is a huge incentive to join this program. And that is also something that we focus on tremendously with our clients. It has a true large financial benefit. And lastly, like we covered earlier, having enough lives in your ACO to reduce any sort of statistical variation. You look at insurance companies, they've learned how to manage risk. They just try to get as many partners and clients as they can to kind of level out the playing field and make sure that they're not going to fall under that red line. Next slide, please. And you've probably heard this before, but another key to winning is team-based care. Getting your docs engaged, getting that physician buy-in while also reducing physician burnout. I actually recently read just yesterday that 2 out of 5 doctors say that they're burned out. Team-based care can truly improve that condition. And that's helping your other medical staff work at the top of their licensures as well. And in turn, in doing that, you can generate additional revenue streams, like nurses billing incident 2. For example, like I mentioned earlier, having your nurses conduct 95% of the annual wellness visit and having the physician come in at the end of the visit to have a conversation with the patient. Next slide, please. I have a bit more on that topic. So if you take a look here, this graphic shows how much nurses truly excel at conducting these annual wellness visits, which is something that we focus on a lot as well. They can hit all of the quality metrics just as well as physicians can, if not better in some cases. Next slide, please. Now, these nurses can also generate new avenues of revenue for your practice that you may that you may have not realized before. It's different, obviously, if you're cost-based reimbursed. We do work with a lot of rural practices, so we're certainly familiar with that. But if you're not, your nurse can bill for multiple different services, like you can see on the slide here: wellness visits, cognitive assessment, behavioral health, advanced care planning, and CCM. Next slide, please. Now, here's a quick case study that I'd like to share with you guys. We conducted this with one of our partners, Tampa General Hospital, down in Florida, who joined our large CaravanHealth Collaborative ACO, that one with 225,000 lives at the beginning of 2019, so back in January. And they've been able to generate significant population health revenue within just 6 months of joining the program. They've done tremendous work getting organized and putting in place care protocols that have really worked for their community. Obviously, you can see on the slide, they focused on team-based care, physician buy-in, taking a deeper look at some of their data to kind of understand where things are happening, and obviously focusing on wellness and prevention. Next slide, please. Now, we spoke a bit about team-based care on your side. However, we also bring a team to the table, and we call them our regional teams. And these teams are led by the regional vice president, and the regional vice president is supported by 7 other subject matter experts. You can see on the slide the clinical leader, interoperability specialist, compliance officer, integration analyst, data analyst, quality specialist, and the practice improvement manager. It truly wouldn't make sense for us to, give you an account manager that could deal with all of your problems, because it's really hard to understand every piece of this program and how to be successful in it. And so we just took, the best folks in our eyes and and allowed you guys to have them as a resource. Next slide, please. Now, I talked a bit about the portal earlier, and here's a bit more about it. Like I mentioned, it's a secure HIPAA compliant document sharing space. It's kind of your one-stop shop. HIPAA compliance is very important for us too. You don't have to, sweat at night thinking that you've compromised some of your patient information. That's certainly something that none of us want. And like I mentioned earlier, you can take a look at an event calendar that we supply to you, a resource library, direct links to Relias, which is our online educational system for our clients, our help desk, which you can ask a question to any Caravan member at any time. And lastly, you have access to the Caravan Compass, which is our in-house analytics module. And the next slide, I believe, has a bit more information on that. So for example, Caravan Compass can provide you reports that look similar to this. You can, for example, take a look at your per patient spend on an annual basis. And so, for example, if you look at one of these, they're all fairly similar. That orange line would be your community and how you match up against the green and the blue lines, which are the green is the rest of the ACO that you're participating in, and then the blue line is across CaravanHealth. And so it's always nice to kind of see how you match up maybe against other partners that we work with of similar size, or just the rest of your ACO and partners that we have across CaravanHealth. Next slide, please. A bit more about Caravan Compass. For example, we can take a look at utilization patterns. We can take a look at top 10 DRGs and ED utilization by severity level. Pretty much anything that exists within your claims feeds or your EHR, we can create a report from, and we are very, very proud of that. Our data analysts work very hard to kind of get this system up and running, and our clients have definitely shown or expressed, a lot of happiness that they can access these reports at any time. Next slide, please. Now I'll get a bit more into kind of some ACO details on these next few slides. Now, to kind of set a baseline, some of you may have read the new rule for the kind of the new structure of the Medicare Shared Savings Program, but I'll briefly cover that for you right now. So there's kind of two different sections to this new program. You have the basic section and then the enhanced section. The basic section involves 5 different levels. You can see ranging from A to E. A and B are upside only, and so it's similar to the old track 1 model, one-sided risk. And then C, D, and E are all two-sided risk. And then you can take a look at that highlighted red column, the enhanced column, which is the most possible risk to take on. Now, the ACO that we will propose for any newcomers like you guys to join would be an ACO that starts in level A. We would set that up for you guys. And then part of the new rule is that every ACO has to jump at least 1 level every year, ending in level E. They're not going to force you to jump into enhanced. That's simply unreasonable. And so the ACO that we would propose to you would be started in level A in year 1, level B in year 2, and then after year 2, we would kind of analyze everyone's performance, have conversations with each one of you guys on how you're feeling about risk. And let's say those conversations go well, we would propose that you jump straight to level E. And I'll talk about why that is right now. If you take a look at that bottom row, that QPP status, levels A through D are all just a simple MIPS APM. However, that level E is an advanced APM, which comes with a number of benefits. Next slide, please. Now, when we propose to you, and if we propose to you to jump into a risk-based model, that's no easy decision for any organization at all. Risk is something that maybe some of us have had experience in, and some of us maybe haven't. However, we've come up with a program to kind of make jumping into risk much more attainable, and we call it our Caravan Smart Risk program. Now, if you're able to catch on that last slide, level E requires 4% to be at risk, meaning just about $400 per patient has to be in an escrow account or a line of credit. However, in our Smart Risk program, we actually take 75% of that off of your plate. So if you had 4% at risk, $400 per patient, we would take $300 of those $400, and then you would only be on the hook for $100 per patient. And with our historical ACO performance, we can, for the most part, predict that neither of us are going to have to write a check to CMS. First of all, you'd only ever be on the hook for 1%. Anything past that, we would cover. But we are so confident in our model and in our services and in our success in the program that we are willing to take on 75% of the risk for you and have you guys be successful in the program. Next slide, please. Now, obviously, there's some benefits to taking risk. We all know that CMS is, frequently dropping carrots and sticks for participants to enter into risk-based models and other initiatives. So first, any ACO participants taking on downside risk are going to get immediately a 5% lump sum bonus, and that includes specialists. How great is that? And secondly, there's a number of increasing incentives, like reducing the risk corridor to 0.5% or lower, which increases your chances of earning shared savings. You can direct admit to SNFs. You can telehealth to patient homes as a billable visit when you're in risk. You're exempt from MIPS and meaningful use. And then lastly, beginning in 2026, every year a clinician does not take risk, his or her lifetime earning potential actually decreases by 0.5%. And if you kind of understanding me, it's going to be difficult to recruit physicians to your practice if you're not under a risk-bearing model. Next slide, please. Now, if there's truly anything that I'd like you guys to take home from this presentation today, is scale truly matters. There's no bigger danger to your participation and your results than the size of the ACO. You can be doing all the work in the world and have, providing some really great patient care. Your patients can be very, very satisfied with the care that they're receiving, but your ACO results could be all over the board. Year after year, you could have 10% savings one year, which would be great, and then 12% losses the next year. And if you kind of take that concept going into a risk-bearing model, then you don't know what's going to happen every year. And we truly don't want you guys to have to write, dumb checks to CMS for something that you can't control. But if you do decide to join an ACO, make sure that it's a large one. Make sure that you're giving yourselves the best chance to be successful. And I believe that's all I have for today. I think I can hand it off to Susan and Nancy.
Hi, good afternoon. I am Nancy Spencer, the CEO at Alcona Citizens for Health. Thank you for having me and Sue Hose, our Health Center's Chief Finance and Operations Officer, as part of your day today. I'll start out with just a brief overview of our organization. Next slide, please. Okay. Alcona Citizens for Health is a federally qualified health center that began in 1978 in one county and expanded to 7 counties in northern Michigan. We have 14 primary care clinics. Our health center serves 31,000 unduplicated patients per year, and approximately 25% having Medicare coverage. As of today, we have approximately 5,400 traditional Medicare attributed lives. In 2018, we had approximately 2,400. The increase in 2019 is due to how the attributed lives are calculated, and this is the first year that the attributed lives can be based on not only physicians, but APPs as well. We provide primary care, behavioral health, dental, and pharmacy services, which provide a comprehensive approach to healthcare. In 2014, our organization joined the National Rural Accountable Care Organization, now CaravanHealth. In 2019, we became part of the CaravanHealth Collaborative ACO community. Next slide, please. How we succeed in an ACO. Leadership, support, and commitment. Our organization made the ACO an organizational priority. We assigned roles which include an ACO champion, physician leader, care management, corporate compliance, representation from key leadership staff, and information systems. We hold monthly steering committee meetings and review our goals and objectives with full department representation to demonstrate that we are fully behind the program as a leadership team. Physician champion. Dr. Kathleen Dunkel has been with Alcona Citizens for Health for over 20 years. She's dedicated to the program and its vision, and that's one of the reasons we asked her to be our physician champion for the ACO. Executive leadership made a commitment to allow Dr. Dunkel dedicated time to spend on ACO initiatives, and this was key. Dr. Dunkel spends approximately 8 hours per week for ACO administration time, and her remaining hours she sees patients in the clinic setting. And this helps lead to provider buy-in on the next bullet. Dr. Dunkel visits all of our sites, and she provides education and support. She has credibility, peer-to-peer, and relates to the provider their day-to-day challenges. She walks the walk, which we have found is one of the most important aspects for us to succeed in the ACO. Our providers feel the one-on-one and group trainings from a peer are very beneficial, which really, that provider buy-in is key to the success. Electronic health record with reporting capabilities. Having an electronic record with a robust reporting capability for populations, it goes hand in hand with late beam reporting. We are able to overlay reports and determine our focus priorities for our patients and for our quality measures. We have found establishing collaborative relationships is also beneficial for our organization, especially since we are not a hospital setting. Therefore, we work with local hospitals to establish a system for hospital follow-up to prevent readmissions, ED utilization, and patient referrals. Caravan has been providing our organization support both individually, as a health center, and as a community for group presentations and educational workshops to make us succeed. We feel like a partner in this initiative, and they do value our input. Next slide, please.
Okay, hi, this is Sue Holt, and I'm the Chief Finance and Operations Officer with Alcona Citizens for Health. One of the other things that we'd like to share is what we've gained from participating in an ACO. Beginning with the improved care for our patients. We are able to address quality aims such as prevention care, care of chronic illness, high prevalence conditions, patient safety, patient caregiver engagement, and care coordination. We have implemented our ACO initiatives to our entire population, which benefits not just our Medicare population, but the entire patient population. Another thing we've developed is a robust care management department. As of today, we have 12 care managers on staff, 6 care connectors, and 4 community health workers. This staff coordinate care and services, including community resources. They assist the patient with the navigation through the healthcare system. They provide transition of care management and promote patient self-management of chronic disease. We also now have access to CMS claims data. This information is provided to us through the LightBeam software. We can see the total picture of where the patient has had care. Alcona is located in northern Michigan, and we do have several patients that will go south for the winter, whether it be Florida, Arizona, but we call them our snowbirds. And what's nice about seeing the total picture for our patients is that we can see where they are receiving their care, what type of care they're receiving throughout the year. That's been very beneficial for us. We're able to pull multiple reports from the LightBeam software, which identify those patients also that need the most attention. Another thing we've gained is our enhanced health information reporting. We found we needed a sophisticated electronic health record system to pull reportable data. We have been on an electronic medical record since 2009, and while that was proving beneficial for us, we learned how to really use our own system and making sure that we are documenting data in the correct place in order to pull that reportable data. So that was key. And of course, what we also have gained from participating in ACO is the shared savings. We have received shared savings in our 2017 calendar year as well as our 2018, and that savings goes along to assist us with some of our operational expenses. Next slide, please. I'd also like to talk about some of our successes. Obviously, some patient success stories. We have many. Patients have experienced increased mobility, medication compliance, weight loss, including improvement in clinical measures such as diabetes, screening for future fall risk, colorectal cancer screening, and statin therapy. These are some of the measures that we have seen a real improvement since we have joined the ACO. And then, of course, again, the success of the shared savings. Next slide. So we have, along with Taylor's information, that's provided our own information here. We are happy to receive questions. Our email address is there. We've certainly learned along the way and had our own questions along the way. So we'll turn it back over to Taylor and open it up to any questions for any one of us.
Great, thank you so much, Nancy and Susan. If you guys have any questions at all, go ahead and type them in the chat box and we'll get started.
Wonderful. We do have some in the question box already, Taylor. And let me go ahead and get started here. The first one is, how is patient quality data collected and stored?
So that patient quality data is collected through, first of all, claims feeds, and we take a look, and if you are interfacing with us, we are able to get a flat file from your EHR to kind of see some clinical data there. But that is collected and stored on our scorecards. We have an in-house software program that stores all of that. As well, we use Lightbeam Health Solutions, which is one of our population health platforms that we use to assist some of our work.
Yeah, the follow-up question on that was, how often is the data collected? Monthly, quarterly, annually?
That's actually a good question. I think I'd need to get back to you on that and exactly how often we collect it from you guys. So let me get back to you. I apologize.
Oh, not a problem. So how is the data submission handled? So is it through an interface or is it only through claims?
So it's both. It's through claims that we receive back from CMS. Of course, there is that claims lag. And then we take a look at your EHR clinical data as well. And then what was the question? How do we submit it back to CMS for quality reporting, or?
No, they're wondering how the information is coming from the practice to your ACO or their ACO.
Got it. And so, like I just mentioned, we use Lightbeam Health Solutions, not necessarily a point of care tool, but we use that to kind of funnel some of the data that we need to run some of those analytics reports and understand our performance a bit better. But that is plugged into Lightbeam and then sent back to us.
So another question, do the practices need to have an EHR?
Well, it depends on the size. I would say yes. In most cases, it's going to be more beneficial for you to be on an EMR system. But if you are a very small practice, then you can still get by. But I believe one of the requirements being in an ACO moving forward is that you must be on an EHR system. And so I maybe would have to have a conversation with the individual to kind of understand their situation a bit more to figure out how you would be able to move forward in an ACO if you decide to go that route.
We have here at Alterum, we have a lot of connections with behavioral health practices. Do you have a focus on behavioral health at all?
We do have initiatives around behavioral health, and Nancy and Susan may be able to speak to that better than I can. I am not a practice improvement manager. However, I believe we do have initiatives that's surrounding behavioral health that could help with our clients.
Sure. Hi, this is Nancy. We do have, there's a couple clinical measures, one being like the depression screening and follow-up. That's one area that we have the on-site behavioral health staff that can assist with that, as well as when a patient comes in for an acute visit, or if it's a wellness or prevent visit, to do the depression screening, and then if any areas indicate that they need further maybe assistance or counseling, then we can refer right in-house, or if there's something more extreme, we can of course refer outside of our agency. But there are a couple, and I think one of the things too is they all kind of tie together a lot of the measures with the interdisciplinary approach, the behavioral health, care managers, and they all kind of tie together. But depression screening would be the big one for behavioral health.
Thank you. The next one is a little different here. It says, do you plan to participate in CMS initiatives, or are you also a clinically integrated network, or CIN, that intends to participate in multiple value-based contracts, such as Medicare Advantage, commercial, or managed Medicaid?
That's a great question. We do have plans to move into the commercial ACO space, Medicare Advantage space. And like Nancy was just saying, a lot of this work does tie together. If you can improve quality in one place, then why not improve quality in all places? It does make a lot of sense getting into Medicare Advantage and getting into other commercial ACOs, and even participating in other Medicare initiatives, maybe not just ACOs. We believe that CMS should be releasing, maybe even before the end of this year, a rural-focused program. I believe Alcona was part of the rural AIM-funded ACO program, and we believe that CMS will be releasing another similar program, potentially AIM 2.0, maybe something a little bit different. But we do plan to kind of spread our wings almost, and move across some multiple programs that can assist our clients' success.
Wonderful. So we do have someone who is asking about enrollment. Do you have any deadlines, or what would be their next steps?
Of course, yeah. So every year CMS opens up the ACO application in, I believe, the middle of May, maybe even beginning of May, and then you have traditionally until the end of July to apply for the program. And so next steps would be, well, talk to us, have a conversation, let us get to know each other and understand, what the best decision for you is. Obviously, we don't want to push you into any program that your organization would be uncomfortable with or even unsuccessful in. But we would have a conversation, and if all goes good, then we'd have you fill out what we call an application worksheet, which contains all the necessary application information. It's very straightforward, to believe it or not. They've made the application a lot more simple since the program first began. But then you apply for the program, or we would apply for you by the end of July, before that first deadline. And then for the next few months, I believe August, September, October, CMS comes back to all the applicants with several questions about their applications, and just some clarifying questions. And then we answer those questions, submit them back to CMS, and then hopefully hear back from CMS that you've been accepted into the program. And we actually have a 100% acceptance rate, which is awesome for us and our partners. So if you have any further questions on that, I'd be happy to answer those as well.
Right, we do have a question for Nancy and Susan in terms of what are your challenges that you find having joined an ACO, in particular CaravanHealth?
So that's a good question. And we talk a lot about our successes, and of course, this does not come without challenges as well. I think one of the few things we really wanted to take out of it was really starting out with the leadership in getting the total commitment and priority. But one of the few areas that we did see as a challenge, of course, provider buy-in is one of the big ones that you really need to focus on, in making sure that all staff, not just providers, but they understand what the priority is, what the benefits to the organization, to the patient, and the communities you serve. Also, the patient buy-in. A lot of the patients for their wellness visits, the Medicare wellness, they don't all really want to come in just to do that. They want to either do their preventative visit, or if they have a planned visit for diabetes or whatever condition they may have. So to get in for the annual wellness visits, we still see that as a challenge today. But if it really comes from a provider, we really try to have during the wellness visit that a provider talks to the patient and talks about the importance of, let's lay out your plan for the next year. to get that buy-in from the patient. So we've made some progress with that over the last couple years. There's also, the cost of some ancillary staff that you can't bill for, such as, your community health workers. Care managers, you can bill. There are certain aspects you can, but there's always some cost of some of the other ancillaries, some of our care connectors as well, trying to navigate with patients who have been discharged from the hospital to get their hospital follow-up. Just some of the connecting of gaps in care, some of those behind the scenes, and our healthcare workers navigating patients if they need assistance with, resources for the cost of medications or transportation to and from their appointments. We were fortunate to be a part of the APMs program last year and for 2018. So we were able to have really work our programs and increase our workflows and processes. And then now in 2019, there is, of course, the per member per month fee that we pay for the attributed lives. So that's something we're focusing on this year and trying to gauge what our shared savings will be in 2019. But it appears our ACO, is on target if we keep moving forward in the same direction we have. Those, I think, are the top challenges. Sue, do you have any other?
No, I don't think so. I think you touched on all of them.
Susan, thank you very much, Nancy and Susan. Here's a question. It says, you said that the compare community to the ACO. What is the source of the community data?
So we take a look at your claims feeds, and it really depends on what data point that you're looking at, but it's usually your claims feeds and then juxtaposing that with your clinical feeds from your EHR.
Okay. Is there a interface that's required from the EHR to your system, your repository?
We don't have that as a requirement. Again, it's better to have a conversation about this with the individual, but for the most part, if you have under 1,000 attributed lives, Medicare lives, to the ACO, then you can do without interfacing. But if you have more than that, then in most cases it makes sense to do the interface, and that does come with a fee. We charge $10,000 per interface fee, or excuse me, per interface. And we've interfaced with many EHRs. And so tell us what you got, and we'll tell you that we most likely have interfaced with that EHR before.
Great. You've touched on this a bit, but can you discuss any fees to join the ACO, and are there additional fees?
Of course, yes, I'd be happy to. And so our cost is for our comprehensive services to join the ACO is $5 per member per month, as well as if you are new to the program and we are applying, filling out your application on your behalf, there's a $10,000 application fee, and then, like I just mentioned, the $10,000 interface fee if you choose to do that.
Wonderful. Thank you. How many clinicians or groups has CaravanHealth asked to leave an ACO?
That's a good question. I don't think I know the answer to that. I think I could probably count on one hand. For the most part, our partners that they understand this program, and they are very happy with the services, and they understand that they need to put time and resources into this as well. And so I think I could probably count on one hand. I want to say 2 or 3, but don't quote me on that. But if you'd really like to know, I can get that answered for you.
Kind of piggybacking onto that, if you've got providers or organizations that aren't performing as you expect them to or as they should for the ACO, is there a process improvement plan or anything that that's in place?
Like I mentioned, when we put someone into remediation, we have their regional vice president and a couple of other of our regional team members kind of discuss with them, meet with them on a weekly basis on meeting certain goals depending on what areas they're struggling in. But yes, we do put together kind of a remediation plan for them and goals to meet, to get out of remediation. And then if they don't meet those certain goals on the areas that they're struggling in, then that's when we ask someone to leave the ACO. I hope that answers your question, but if not, you can ask something a little bit more specific, and then I'd be happy to answer that.
Okay. What level of support do you provide for your members?
I think we provide a lot of support. Nancy and Susan, you can speak on this as well, but if you remember that slide where we showed our regional team, we have specialists in every area of the ACO. And that is done on weekly calls, monthly calls, steering committee meetings, quarterly meetings, in-person seasonal workshops for you to attend. And for most of our clients, we have a workshop that's within 200, 250 miles of them. So easily can be, driven there and back in a day. Maybe not easily. No one likes driving too far. And then lastly, we do have an end-of-year CaravanHealth Symposium that we hold for all of our clients to attend, which is a great educational opportunity. We have tons of industry speakers and panelists and certain sessions, on AWVs or a leadership session. And it's just a great opportunity for you to talk to other clients that maybe you haven't connected with before and talk to them about their successes and how they're dealing with their problems. And so it's a great opportunity to kind of talk to other people in the industry, other people in your ACO, and things like that.
There's a question regarding population health registry or platform. It just says, can you talk just a little bit more about that?
Yeah, so I would say our population health platform is LightBeam, and that kind of helps us navigate the areas of care that's not specifically my area of expertise. And so I can get you some more information on that, on exactly how we use LightBeam. But Susan and Nancy may be able to help you understand that a bit more on how they use it.
Sure. With the LightBeam, we really rely on that. And that was one area where Sue touched in one of the PowerPoints where we can see in our electronic health record what's happening with that patient. But if they travel to other specialties or to indicator like our snowbirds in Florida, or if they've gone elsewhere for a few months, we can kind of see that full picture, or DME, what's happening, what's their total cost. And then we can kind of take a look at, we've narrowed down a lot where we'll go with provider panels, specific providers. We'll do sites kind of in our 7 counties that we have clinics in. We'll pull site-specific, provider-specific. We'll also pull like top 50 patients maybe who are kind of the high spenders per se. And a lot of times if we find like they have kidney failure, certain things that they are maybe a higher cost patient. And then we kind of really want to weed all of that out to see where we can take some of those quality measures, figure out if it's specific to chronic disease, again, or if it's a provider panel, just to see what areas we can look at for gaps in care and improve the quality of health. So we really rely on LightBeam a variety of ways. It just really gives us that total picture that we've been looking for.
Thank you.
Absolutely, thank you. Next question that has just come in is, when referring to per member per month cost, are you referring to the patient or provider?
Good question. I apologize for not clarifying that, but that is per patient, and that is, like I believe Nancy said it earlier, and that is per attributed patient in the ACO. And so, yes, per patient.
Thank you. The next question is, do you see the $300 MMSP bonus in perpetuity, or would you see the number decrease as ACOs get traction and have success?
I believe you're speaking about the HCC coding bonus, or perhaps the 5% lump sum bonus in risk. But either, I mean, they're both there, and I don't see it, really going away. It's an incentive that CMS has. Both of those are incentives that CMS has released, for the program, whether you're in risk or not. And so as ACOs get traction, those numbers are going to be, even more attainable. So especially for the HCC coding.
Thank you. Here's another question in terms of supporting an EHR within the practice. Do you actually supply resources for a practice to become more, to use their EHR in a more optimized manner?
Oh, sure. Yeah. Those are our integration analysts. They'd be able to help kind of improve your workflows surrounding your EHR and kind of best practices and also your peers in the ACO are also good resources for you guys as well. And that's the key, that, we want to connect you guys with, other participants who are, going through the same program that you are, potentially even dealing with the same issues. And so we are not the know-it-all group. Obviously we want to share as much information as we can, and whether that's us sharing information with you or our other clients sharing information with you. I think that's the kind of beauty of this whole program and this collaborative approach, is that everyone is in this together. And that's kind of where we actually got our company name, CaravanHealth, is, join the caravan, if you want to go far, but if you want to go fast, go it alone.
Well, very good. That is actually all of the questions we have right now, so thank you very much for everyone. Is there anything else, Taylor, Nancy, or Susan, that you would like to touch upon?
That's all I've got. If you guys have any other questions, feel free to reach out. I'm happy to have a conversation or answer your questions over email. And Nancy and Susan, I know they mentioned they'd be happy to speak as well, and we very much appreciate that.
That's awesome. Well, we want to thank you all. And again, we're going to send the questions and the presentation out to everyone that has registered for this webinar. And if there's any additional follow-up questions, please send them to me, sylvia.romer@alterum.org. And so thank you, everyone, for joining. And thank you, Taylor, Nancy, and Susan. We truly appreciate it.
You're welcome. Thank you.
Thank you.